The Limit Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limitchildren.org.
An index of suspicion for it and how we can diagnose one and the principles of management. So for this afternoon's presentation, we have
Dr. Morakinyo, Esther, pediatric medical officer,
and my humble self, Dr. Nwala Gabriel, a consultant pediatrician. So the presentation will follow. Okay, before we go into the presentation, let me give us a brief introductory remark about who we are. We are from the Limit Children's Hospital, a designated specialty hospital for general pediatrics, neonatology, adolescent medicine, and pediatric neurology. And the hospital draws from the rich experience of healthcare provision, and it's a corporate patient-centered work ethic, that drives us, helps distinguish us from other health facilities around. And we enjoin you to come draw from our ocean of experience, and you will not regret it at all. So the discussion will follow the following outline, and let's take off with the objectives. It's our desire that by the end of this presentation, we should be able to identify babies or children with possible congenital anomalies. These anomalies, the ones that are characteristic of trisomies, should rouse an index of suspicion. When we see some dysmorphic features and some key systemic features, we should be able to have a very high suspicion of trisomies, at least the common life-compatible trisomies, and be able to diagnose them and know how best to manage them. We'll start with the case series.
Okay, so we're going to start with the case series. These are cases that we have managed in our center, and so I want everybody to listen attentively because there will be some questions for us to answer from this case series. So the first one is a 9-year-old female who presented to our children outpatient clinic with abnormal behavior and between which her older sibling has no problems. Now, on examination, child had mongoloid fascia, was laughing incongruously with global hypotonia. Now draw a person's test.
I want us to just keep at the back of our mind that we may likely ask our which of the trisomies will give you these outlined features. Now, this child never visited any facility, didn't come to our facility, I should say, until when she was 9. And the reason why they actually came was because of the abnormal behavior. On 21, which gave it away, and we've been able to manage the child as indicated by a multidisciplinary approach, and which these have been able to witness some clinical improvements in line of the behavioral and emotional.
Okay, so our second case series is the case of a 4-day-old male neonate who was brought into our facility on account of no opening of the anal canal. And this was noticed on the 2nd day of life. So an examination of the child was found to be dusky. Child was not pale, was active with some dysmorphic features, which include upward slanting of the eye.
So let's just share this slide so that we'll be able to.
Because there are questions after, so we want everybody to follow us as we are going, so we'll be able to answer our questions at the end of the case series.
This one. Is this one or this one? Yeah. This screen is not good. That's another thing. This is English. Patience. Very close and deep again. Thank you.
Okay, we are so sorry for the break in the transmission. So just to continue, our second case series, as I was saying, is a 4-day-old male neonate, the first of a set of twins, who was delivered at 34-week gestation and was admitted into our neonatal intensive care unit on account of absence of anal opening, have been noticed on the second day of life. On examination, neonate was looking dusky and had some dysmorphic features. Now, the dysmorphic features include a frog-like position, upward slanting of palpebral fissures, a pseudomicroglossia, unilateral right palmar crease, high arched palate, hypertelorism.
Okay, so the palmar crease was transverse, had a single palmar on the right, had a high arched palate, as well as widely spaced eyes or narrowed interspaced nipples. So the examination finding revealed a conscious child that had the anterior frontal was fine, but had global hypotonia, which will explain the frog-like posture that was witnessed. And the cardiovascular examination finding revealed a grade 2/6 murmur, which was maximal over the left lower sternal border. The urogenital systemic examination revealed just a depot at the anal opening with no opening at the opening of the anus. So this warranted an invite for a pediatric surgeon to review, and a colostomy was offered for the child, and child is being followed up for definitive anorectal reconstructive surgery.
Okay, so our third case series today is a 1-hour-old preterm male neonate that was delivered via emergency cesarean section at 35 weeks plus 1 day on account of premature rupture of membrane. The ABGA score was 8 in 1 and 9 in 5. On examination, we found an active male, pink in afebrile, with some dysmorphic features, and these include flat nasal bridge. There was upward slanting of the palpebral features. The child had a flat occiput. The child had short and sturdy fingers. The child had short neck, and there was low set ears with widely spaced nipples. Now, CNS examination showed a conscious and alert child with global hypotonia. An echo was done for the child, and the echo revealed a large ostium VSD and also a patent ductus arteriosus.
Okay, so that brings us to the teaser for today. Now, having listened to the 3 case vignests, I would want us to attempt these questions. I know we have a very active participants, good listenership.
High cerebral,
so
high cerebral.
very highly cerebral participants. So I want us to put up at the Q&A section of the thread, what do we think is the common diagnosis for these three cases? Then what are the two differential diagnoses and the principles of management? So while you're trying to put up the answers to these questions, I want us, Esther, what do you think? We'll just continue with the presentation. So at any point you are able to come up with I think we have one person that has say the chat is disabled. Just put it up in the Q&A section. Just type the answer in the Q&A section. Just where you've put up this statement, just put your answer there. We'll be able to read and share with the other participants. Okay, so we'll continue while we wait for answers to the questions.
Okay, so by way of introduction, trisomies generally are characterized by the presence of 3 chromosomes instead of the normal 2 chromosomes that we have. Now, a trisomy is one of the most common numerical errors of chromosomes. And then we have trisomies that are from errors during gamete production, and this leads to an abnormality in the number of chromosomes in each cell.
Okay, so let's bring it down a little. Okay, for an individual to be formed, we know that half of the cells will come from the mother and half of the cells will come from the father. But there is what we call reduction division that brings about this haploid number of cells from each of the contributors to the individual. So if in the process of producing half the number of chromosomes or the gene or the genetic makeup that will form the individual, there are some errors. Maybe at a particular position, there is failure of separation or an abnormal chromosome gets attached to a particular position. So that will lead to a numerical abnormality, as in you have a higher number of chromosomes than the individual would have otherwise had if everything had gone on smoothly. So in the course of this presentation, we'll also try to bring this discussion up to the point of what brings about this error, as it were, in the manufacturing line or the production line of this chromosome.
Okay, so generally, chromosomal abnormalities occur in 8% of fertilized ova, but only 0.6% of live-born infants. And that's to say that 50% of spontaneous abortuses have a chromosomal abnormality. And trisomy can occur in any and can also be a mosaic. Because of presentation, we'll shed more light on what we are saying. Now, most cases occur due to non-disjunction. Some series say about 92.5 to 95% occurs due to non-disjunction, while the others can occur due to paternal non-disjunction or ribosomal translocation. Now, as we go into we shed more light on all of this.
Okay, so let's go down the memory lane a bit. How did this whole trisomy issue come on? We've talked about the fact that there is a more number of chromosomes than there should have been in the individual, leading to this trisomy. The trisomy means that there are, instead of a pair of chromosomes, you actually have 3. That's trisomy. You have 3 genetic makeup at those particular positions where the syndrome, as it were, occurs. So if there are random errors or spontaneous errors during the reduction division just before fertilization, as in what brings the contribution from both, what brings about the contribution from both the male and the female counterparts before the fertilization happens. So that random or spontaneous error will bring about this trisomy. Now, in 1866, John Down was able to describe a clinical syndrome of trisomy 21. He didn't know as at the time the chromosomal basis for this clinical syndrome he described, but because he was the first person that described it in 1866, the disease condition was named after him. Down syndrome, not Down's syndrome. Is actually somebody's name, the first person that described it. So, but however, you know, some years down the line, one other individual, Jeun, was able to now describe the chromosomal basis for the problem. So, and that's after he was able to, demonstrate that it was the extra copy of chromosome at that position 21, the condition was now known as trisomy 21. And so whether we say Down syndrome or trisomy 21, we're talking about the same condition where there's an extra copy of chromosome at that position 21. So other people were able to also demonstrate other clinical syndromes of trisomies, like Thomas Bartholin in 1657 was the first person that observed a constellation of clinical signs and symptoms which fitted into the condition we now know as Patau syndrome. But Patau was part of the team of doctors, Dr. Eva Teman and himself in 1960. This was some centuries later, were able to also document the chromosomal nature of the condition that Bartholin, first observed. But I don't know why Down was able to describe the clinical syndrome and the disease was named after him, even after some other person found the chromosomal basis. But this other condition now, instead of us to be calling it Bartholin syndrome, we are still calling it Patau, because Patau actually, it was just an it was just an observation. There was no effort, by him to try to describe or to, explain what really happened. He just observed it and moved on. But Patau was the person that actually did the documentation, not just documenting, but was able to, relate the condition with the chromosomal abnormality that led to it. John Hilton Edward and colleagues in 1960, following a research, this young man now did both works. He was able to describe the findings in a neonate that had multiple congenital anomalies and was equally able to demonstrate that it was due to an extra copy of chromosome at the position 18. So the third common trisomy was named after him, trisomy 18, also known as Edward syndrome, because he was among the team of researchers that were able to describe it in 1960. So those, this is just the historical background of the three common trisomies that we will find commonly in our practice: Down, Patau, and Edward syndrome.
So just to shed more light into the pathophysiology of trisomies, earlier in the presentation, we had said that most common cases occur due to non-disjunction and a translocation, a Robertsonian translocation. So the non-disjunction can occur at any point in cell division, either mitosis or in meiosis. Now in meiosis, the abnormal disjunction can occur in either meiosis 1 or meiosis 2. Irrespective, non-disjunction is due to an error that brings about unequal distribution of a single chromosome pair in cell division, and this now produces daughter cells with either 3 copies of the involved cell or 1 copy. So one cell has 3 copies while the other one has 1 copy. That brings about the trisomy. So what happens in maternal disjunction? In meiosis 1 occurs around 11 to 12 weeks in fetal gestation, but at prophase 1, it halts for several years until ovulation. And at ovulation, what happens? There's an increased level of FSH and LH, and this starts the process of meiosis again and completes it. And now begins meiosis 1, meiosis 2. Now at meiosis 2 is halted again at metaphase 2 until fertilization. At fertilization, what happens? Once the sperm pierces the cytoplasm, that completes meiosis 2 for that particular oocyte.
That's cytoplasm of the ovum now.
Ovum, yes. That completes meiosis 2 of that particular oocyte. So that's to say that the oocyte that is released just after menarche has the shortest wait period. And the oocyte that is released just before menopause has the longest arrest period. And this kind of explains why some of these chromosomes are vulnerable and at risk of environmental hazard that causes the non-disjunction in them, because of the long wait period that the chromosomes stay before they are fertilized. And that's where we get the advanced maternal age.
Okay, there's actually a series that tried to relate the risk of trisomies vis-a-vis maternal age. It's been documented that women that conceive between 15 and 29 years of age, they have a lower risk. There's a lower incidence of trisomies, the 1 in 8,500 deaths within that period, 15 to 29. Whereas between 30 to 34, the incidence increases to 1 in 800, while for women between 35 and 39, the incidence further increases to 1 in 270 live births. So for women that now conceived above 45 years of age, the incidence is quite high, 1 in 50. So that tries to let us understand that the longer the wait period before this fertilization happens, the higher the risk that one of the chromosomes may fail to separate. So that incidence that is high with increasing maternal age, explains why we have what Dr. Esther just described. Okay, so this is Robertsonian translocation. Now here you can see that the one of a portion of the gene at position 21 got attached to this point. So in the genetic makeup, we have 46 chromosomes, balanced chromosomes, as in the number of chromosomes is actually complete, but something went wrong at this position. So instead of having a pair of chromosomes here, we have part of the chromosome going to attach to another one at this point. So whereas the individual will have a complete number of chromosomes, you have an additional copy of chromosome in one of the cell pairs of chromosomes. So this will still give you some of the phenotypes, the features of Down syndrome, for instance, because whatever these cells here would have been able to help the individual to form, the brain, the heart, and other vital organs, because there is an error in this genetic makeup, you still find those features in the baby, but just that there is no extra copy. But because the features are in keeping with what you find in other children that have this the typical phenotype, they are still classified as trisomies because phenotypically they appear same as what you find in those with extra copy.
So this is a slide just showing us what we're talking about basically. So you can look at the first picture. Yes, first picture, we can see that we have 3 pairs of chromosome at position 13. And if you're seeing, if a karyotype is given to you in clinic and you see this, this should tell you that there's an extra copy at this position, and this is most likely trisomy 13 patau. Now, this one here is trying to explain what he just explained to us, the Robertsonian translocation. So you can see that at position 14, there's an extra chromosome that attached at the centromere here. So the extra chromosome was from 13, and so we have 1, 2, 3 here at this position. So there's a translocation trisomy here in this particular slide.
Okay, so it might interest us to know that when there is a breakage of a chromosome, either from a particular position or the other, there are some positions of some locations that these breakages might end up attaching to. Positions 12, 13, 14, then 21, 22 are the places where extra copies of chromosome might likely go and attach. But the features you see will depend on where those chromosomes are coming from. Okay, you will be like, why this one is at position 14? Why are we not calling it maybe trisomy 14? The thing is, the gene that are different positions, there are some specific things that they help the individual to produce. For instance, genes at position 21 are involved in brain development, cardiac development. So that's why most times when you find children with this condition, they tend to have intellectual disability because the cells in charge of brain development is affected. They also have a good number of them, like for patau, 90% of them will have cardiac anomalies. For Edward, 90% of them, for patau, 80% of them, and for Down syndrome, 50% of them will have congenital heart disease. The reason is because the gene responsible for the formation or the structural development of the heart is from that place. And once there's any error, in the gene, then it will affect the production as the production line. Okay, so we'll be looking at some very interesting pictures showing the difference. So these are the things that when you see children in clinic, when you see patients that present to you, or if you see some of these features, it should rouse your suspicion about some different conditions. Okay, for this one now, we are seeing a child with a unilateral cleft lip, although they labeled it as cleft palate. When you look into the mouth, the palate, you know whether there is actually a communication between the mouth and the nasal cavity and all that. That will help you know if there is cleft palate or not. But it looks as if there is actually cleft palate here. You can see the low set ear will show us how to demonstrate low set ears. Then there is also microcephaly, but microcephaly will have to be objectively demonstrated when you measure the hospital frontal circumference. So at birth, yes, it's expected that OFC should be 35 plus or minus 2 cm. That's between 33 and 37 cm should be the normal head circumference of a newborn baby. So if you find a newborn whose head circumference is less than 33 cm, it should tell you that there is actually microcephaly, and that's one of the features you find in trisomy 13.
Okay, so in this slide, we can see that this child has an extra digit. Now, so the kind of polydactyly that is seen has to be characterized because it tells you or it gives you the index of suspicion, what kind of trisomy you're dealing with. So if you place the child in anatomical position, I don't know if anybody can, I don't know if you can see my hands like
so
this.
if you keep your hand, you spread out your hand and face your palm to the front now, that should be the anatomic position. So what you find in trisomy 13, for instance, is post-axial polydactyly, meaning that if the child is in anatomic position and an imaginary line is drawn that cuts across the middle of the palm, the part that is closer to the body, is pre-axial, while the part that is away from the body is post-axial. So from this picture, you can see that the extra digit is closer to the thumb. So that's away from the body when the person is standing in anatomic position. So this is the kind of polydactyly you find in Patau syndrome, a post-axial polydactyly, not like the one that can be constitutional that you find in most babies. You find them having an extra digit or rudimentary finger close to the little finger. That one is not. That one is pre-axial, not post-axial polydactyly. However, in the lower limb, the opposite is now the case. When the person is standing is in an anatomic position. So the post-axial, while for the lower limb, will actually be close to the little toe, not the other way around, just as you have in the upper limb. So that's that is what you find in trisomy 13.
Okay, so in this slide we can see. Let me see if we can. Yes. Okay, so we can see this first picture. See this infants. Obviously, we cannot measure, but we are seeing that they said there's microcephaly. So when you see a child like this, you want to take the OFC to be sure of what the head circumference is to know if you're dealing with a microcephaly. Also, you can see a reddish discoloration here that shows a forehead hemangioma. This is clearer in this picture. I don't know if you can see where I'm pointing at. Yes, and then you can see the up slanting palpebral features. You can see this is going upwards. Yes. And then you can see the child has a cleft lip and a cleft palate here with a short neck. These are features that are seen in a child with Patau syndrome. Also here you can see scalp defects here. Most musculoskeletal features, abnormal features you find in a child, you should have a high index of suspicion. You're dealing with most likely a trisomy 13 because they usually have a lot of musculoskeletal deformities. You can see a scalp deformity here. And also in this child, we can see, the philtrum of this child is smooth because in Patau syndrome, you have yes. And this comes a lot of the mouthful. And this comes a lot of facial and facial deformities. An example is this smooth philtrum you're seeing here. You see the nasal bridge in this child too is depressed. This is an older child with trisomy. We'll talk about it later in the slide.
Okay, so this slide shows what we call clinodactyly. Clinodactyly, because of the incurving of the little and the index finger, the little finger does as if it's curved towards the ring finger. So when the child folds her hand, like if you see a neonate now, neonates usually make a fist. So if you look at the hand of a neonate and this little finger is on top of the ring finger and the index finger is on top of the middle finger, that is one of the key features you find in trisomies 13 and 18. So this is called clinodactyly. And there's also camptodactyly. Camptodactyly is the incurving that you find in these fingers that bring about the clinodactyly you see when the child folds the hand. This other picture shows what we call rocker bottom foot. So you can see the prominent calcaneal bone, So just try to picture if you're sitting in a rock chair, the chair that will just be, moving to and fro because of the outline of the floor or the leg of the chair. So this is what you find, one of the things that you find in trisomy 18, rocker bottom feet. So if you're seeing a unit that has any of these features, your index of suspicion for trisomy should be very high.
Okay, so this slide shows prehensile foot, and you can see the gap between the first toe and the second toe. This feature is seen in like the monkeys, the apes, to help them grasp on the tree. So in children with trisomies, when you see, especially trisomy 21, when you see this type of signs, also called the sleeper's gap sign, should raise a high index of suspicion, and also look out for other signs of other dysmorphic features in the child.
So I think we have some, let's see whether there are some answers. Okay, Down syndrome, correct. Trisomy, this person wants to place a Down syndrome, Turner syndrome. Okay, I think these contributions are quite impressive. So maybe by the time we get to the end of the presentation, we'll tell us which one. But so far, at least I'm happy that people are following and they are seeing what can help give away the possible diagnosis. Okay, so we move on. Okay, so it's good for us to demonstrate how to know a child that has a low set ear. Most people will say, the ear is low set. Another person will say, it's not low set. There are two ways to demonstrate low set ears. One of the ways is that's if an imaginary line, that joins the lateral canthus of the eye is drawn to the occiput. Now, if it cuts across above that, if you divide the ear into three equal parts, if this line cuts across above the upper 1/3, the ear is low set. Let's say this ear is divided into 1, 2, and 3, and this line is above the upper 1/3, then the ear is low set. That's one way. Another way is to draw a line that joins the medial and the lateral canthi of the eye. So if that imaginary line is extended towards the ear and it cuts across the ear above the upper 1/3, it's also low set. So another way is to join these two medial canthi. If you join this, an imaginary line joins these two places and you extend it laterally and it cuts above the upper 1/3 of the ear, is low set. So those are the ways to demonstrate low set ears. So as you're seeing the child, you can actually do that and know if the ears are low set or not. So if the ears are low set, your suspicion of trisomies should be high as well.
Okay, so this slide shows the facial profile of a child with trisomy 21. So starting from, let's start with this one. We can see the epicanthal folds at this point. You can see this fold just very close to the medial canthi here. And then we can see the up-slanting palpebral features. You see that it's going like this. I don't know if you can see with my cursor, it's going like this. And then you can see this child has low set ears. If you were to draw an imaginary line from the lateral canthi down, you can see that it's going to cut across the upper 1/3 of the eye, then of the ear. And then you can also see the short neck with excess redundant skin. This is not so clear, but usually they have a short neck with an excess redundant skin at the back. And also you can see the furrowed tongue. Usually what happens is they have a small mouth, and because of how small the mouth is, the tongue appears to be protruding out of the mouth. And also we can see the sandal toe that was described earlier. That's the prehensile sign that was described. See the distance between the first toe and the second toe. Also, you can see the single transverse palmar crease. Now, this is to say, once you see a child with a single transverse palmar crease, 45% of cases, some series say children with trisomies, 45% of them have this single transverse palmar crease. However, there is a percentage of normal population that also have, the single palmar.
In the general population, up to 7% of normal children can still have single transverse palmar crease.
Now,
but it's higher in children with trisomies.
Okay, so also you can see this fifth finger is hypoplastic. Like if you compare the length of this with the other one, see how short it is compared to these other ones. And this gap in curved fifth finger, also, all these things just raise your index of suspicion when you're seeing a child. Also, you see the brush-filled spot on the iris of this child. So when you see a child like this should also raise your index of suspicion for a trisomy in this child.
Okay, so we'll go to the clinical manifestation of most trisomies can be summarized into detailed history. The history should span, from the prenatal to the natal and even postnatal period. So a woman that conceives, at an age above 35 is already a red flag. Should know that high increasing maternal age is a risk. Now, if there is reduced fetal kicks, let's say the mother tells you that this my baby is not kicking like the previous ones. Once there is reduced reduction in the movement of the baby, that might point to possible hypotonia. That is another pointer to a trisomy. Then ultrasound, when ultrasounds are done and there is the estimated weight is smaller than what you expect. Let's say a pregnancy, the weight of a child that's 28 weeks is expected to be like 1 kg, and you do ultrasound and the estimated weight is less than that. So if there is intrauterine growth restriction, it also should rouse your suspicion of trisomy 13 or 18. Then if nuchal lucency is peaked in obstetric ultrasound, it should also is one of the screening tests that tells you that that child might have some trisomy. So when you examine after getting the history, the history even at birth, there's respiratory distress or any other thing, maybe abnormal species, and this being a reason for them to present the child to you, also think of trisomy. Then when you go ahead and examine and you find some of the key systemic things that we'll see in the subsequent slides, just know that you need to go further to investigate and confirm the presence or otherwise of a possible trisomy.
Okay, so just to shed more light on the history. So the antenatal history of a woman is very important. The risk factors, the age at which the conception happened is very important. As we said, increased maternal age also increases the risk of a possible trisomy. So the age, even the paternal age, because now new series are saying even advanced paternal age increases the risk of a child coming down with trisomy. So these questions should be asked even from the mother. So reduced fetal movement, as we said, the hypotonia that the child has might reduce the movement in utero. Now children, especially Patel and Edwards, they usually have IUGR and low birth weight, small for gestational age. So those are the things that you could pick from the antenatal history. Now, ultrasound findings during antenatal period is also very important. Some women have polyhydramnios, because of the cleft lip and the cleft palate, swallowing is always a problem. So all those things should just rouse your suspicion that, okay, there might be something going on with this child once you see here polyhydramnios. Also, if a woman has had a child with maybe a trisomy before, this should also rouse your index of suspicion that this one too might, have a trisomy. Now, in women greater than 35-year-old at delivery, it is important that we offer them genetic counseling and even prenatal diagnosis, especially if, aside being 35 years, if they have any other risk factor for a trisomy, should actually give them pre-genetic counseling first and also prenatal diagnosis. Now, prenatal diagnosis can be done, you can do a serum screening. While prenatally, you can do a chorionic villus sampling and amniocentesis. Those are all invasive procedures. Now we are shifting away from invasive procedures to non-invasive ones like the cell-free fetal DNA detection. Those kind of things can be done prenatally. Also, ultrasound too is important, can pick the knockout lucency, the polyhydramnios, even oligohydramnios if you're having a renal affectation in the child. So those things can be picked from your history. That's when you're taking history, proper detailed history from the mother while you're seeing a child. Those things can just draw your attention and raise your index of suspicion to which particular trisomy you might be dealing with.
Okay. Wow. So when the child now presents, let's say the woman has delivered and at birth, you find that the birth weight is small. For, let's say, a time baby comes out with a birth weight of 2.2 instead of the normal 2.5 to 4 kg. That should, rouse your suspicion of possible trisomy. We go ahead to check for any dysmorphic features. We've tried to demonstrate the different dysmorphic features: hypertelorism, low set ears, upward slanting pupil features, single palmar crease, prehensile sign, polydactyly, post-axial polydactyly, rocker bottom feet, all of them. You have to look out for them because, of late we've been seeing lots and lots of babies with some of these features. If you don't look out for them, they might be there and you won't even be able to identify them. Now, if a child has difficulty with breathing, a child is dyspneic, you've tried to rule out other common causes of dyspnea, the child is not preterm, the child, the difficulty with breathing goes beyond 72 hours, that you transient tachypnea of newborn could actually resolve after. Once there's this distress that, like one of the index cases that we shared, this child, the one with imperforate anus, had a respiratory distress that wasn't resolving. We couldn't pinpoint it to maybe congenital pneumonia or prematurity or any of the causes of respiratory distress. So by the time we saw this difficulty with breathing that persisted and saw the dysmorphic features, we requested for karyotyping, which confirmed that the child had trisomy. So if there is a cyanosis, the child is floppy, there is this frog posture like in the second vignette, or there is cleft lip for palates, extra digits, coarse fishes. Children with Downs might additionally have congenital hypothyroidism. So children with congenital hypothyroidism might have those coarse fishes and other systemic findings like pointers to congenital disease, like presence of a murmur, imperforate anus, and other things, should inform the attending physician that a detailed post-resuscitation evaluation and care might be necessary. And this care is what will help ensure that this child doesn't run into any problems and that the necessary things are done to give this child a good quality of life.
Okay, so clinical findings, as we said earlier, a detailed and thorough general examination is on, but these are the times you pick these dysmorphic features. So now that we know these dysmorphic features, when you're doing your general examination, you're looking at the child thoroughly and you're picking out all these things like the frog-like position, they have this partially flexed position. Those are the things you look out for. You look at the hands, the digits, you look out for extra digits, cleft palates, you look at, the occiputs. For instance, we have a flat occiput now if we're dealing with trisomy 21, and then you have prominent occiput if you're dealing with Patau or Edwards. Overlapping fingers, these are the things that you should be looking out for, aside the normal things we do in our general physical examination. Now, for systemic examination, like cardiovascular system, you want to listen. If you already have a child that is having respiratory distress, you have picked 1 or 2 dysmorphic pictures from a general physical examination, you want to listen further for a murmur, those kind of things. You want to listen because they have a lot of cardiovascular, manifestations, either of the trisomy. So you want to pick out for a murmur to know if you want to further evaluate the child.
Okay, so some of the common congenital heart problems that you find in them for trisomy 21, endocardial cushion defect is the commonest cardiac lesion that you find. Ventricular septal defects, patent ductus arteriosus, and technology of Fallow. So 50% of children with Down syndrome will have congenital heart disease. So it's incumbent on whoever that is seeing the child and to ensure that a thorough cardiovascular evaluation is done. Because if you don't look out for, if the respiratory rate, let's say this child comes in respiratory distress, if the respiratory rate is so high, you may not be able to appreciate anymore. So by the time the respiratory distress has resolved and you listen, you might be able to pick the mom, and the location of the mom and the characterization of the mom will tell you which lesion you're dealing with. For even those that are in distress, a 2D echo should be offered, because the 2D echo will be able to, tell you which structural heart disease this child has. Like our index cases that were presented, did echo, and we're able to find PDA and VSD in a number of them. We've also had one that had TOF that even went ahead and did surgical correction. So it's good for us to proactively look out for these signs, and once we find them, offer the necessary treatment modality so that we don't end up having more complications than we should have. So the other systemic findings for the respiratory system, the children with trisomies, like trisomy 21, will have recurrent pneumonia, obstructive sleep apnea, laryngomalacia, and asthma. So if you're seeing them, even when they come to you for follow-up in clinics, look out for listening to their chest. Don't always think that the complaints are not things to look deeply or try to evaluate them for. Recurrent pneumonia is common, and obstructive sleep apnea is common. In the digestive tract, duodenal atresia, tracheoesophageal fistula, Hirschsprung disease, annular pancreas, imperforated is like one of the cases that we presented, and prolonged jaundice. Once you have a child that is having prolonged jaundice that has lasted more than 2 weeks, don't just focus on the jaundice. Go a step further to look for dysmorphic features as well as other systemic affectations. Then, if indicated, you should also do a karyotype. You might be surprised that, like the girl that came in with some behavioral problems, if we had not seen the dysmorphic features and asked for a karyotype, we may just see it as one of those things without knowing that the underlying problem was the trisomy. Now, for the hematologic findings, they have 3 common hematologic problems. Leukemia is found in and that there is 50-fold risk of leukemia in children with trisomy 21. Now, this risk is more in children that are between 0 and 4 years, but the risk is in those that are more than 4 years, there is 10-fold risk of leukemia in them. So within the first 4 years of life, we should try to screen them for possible leukemias. Look at the full blood count picture. When you look at the full blood count picture, and high white blood cell counts, low platelets, peripheral blood film showing myeloblasts, and splenomegaly should, make us even do a bone marrow aspirate to know whether there's leukemia. Both acute lymphoid leukemia and AML as well are both found in children with trisomy 21. But there are other very strong differentials that they may also have: leukemoid reaction and myeloproliferative disease. Now, how you distinguish these? For leukemoid reaction and myeloproliferative disease and leukemia, they all present with high WBC, low platelets, splenomegaly. However, for leukemia and leukemia reaction and myeloproliferative disease, they resolve spontaneously. Whereas for leukemia is there, if you've not offered any therapy, it's not going nowhere. So, but for leukemia reaction and myeloproliferative disease, how you distinguish them is that whereas leukemia reaction will not have any splenomegaly, the white blood cell counts might be high, there might be thrombocytopenia, there might even be blasts on the peripheral blood film, but these will resolve. Myeloproliferative has splenomegaly, in addition to those features I mentioned. So one should also ensure that when you see them, when they come to you with fever that is not resolving, every fever is not malaria or sepsis. The fever can actually stem from a hematologic problem, which can be any of these three things mentioned. Now, for the urogenital system, the males, 100% of them, or most of them, if you like, will not be able to procreate. They will not be able to have any offspring. However, for their female counterparts, 50% of them are able to take in, they are able to give birth. However, it will be important to note that any child or any mother that is a Down's patient has a 50% risk of having a child that is Down's. So this should actually go in when we are trying to counsel them, in line with fertility issues. Pelvic dysplasia is one of the risks that is very high in them. So as they are planning to deliver and all that, just know that there could be some orthopedic emergencies that might require specialists from that angle, from that field to also come in. For the skin hyperkeratosis, you see them having very thick skin with a lot of keratization and seborrhea, dryness, that's xerosis, and perigenital folliculitis. So these are the things that we should look out for when we are evaluating any children that we are suspecting might have Down's, the Edward, or Fatal syndrome. So the musculoskeletal system, that is where you have a lot of signs. The mongoloid fascia. Mongoloid is just like the race, the Japanese, the Chinese people, they have a round face, They also have a flat, and their faces are round and flat. Low set ears, widely spaced eyes, upward slanting papillography. An imaginary line that joins the medial and the lateral contact should actually be pointing upwards. So that tells you that there is upward slanting of the fissures. Epicanthal folds, simian crease, we've talked about the simian increase that is more common, as in 45% of children with trisomies will have single simian, single transverse palmar trees. Cleft lip and palate, sorry for the typographical error. Cleft lip and palate is common in Patao. Polydactyly, postaxia polydactyly is common in Patao. Prehensile fruits seen in trisomy 21. Pseudomacroglossia, the mouth size is normal. The mouth size is small. There's micrognesia. So because of the smallness of the mouth size, the tongue that is normal size, cannot be contained by the small buccal cavity. So there's always tongue thrust. You see the tongue coming out and makes it look as if the tongue is big. You have low sets, malformed ears. There is increased helices of the upper part of the pinna, rocker bottom feet, joint hyperextensibility, short sternum with multiple ossification areas. Then there are a lot of orthopedic issues, capital femoral epiphysis, avascular hip necrosis, atlantoaxial instability. These Downs children like music a lot and like dancing. So while you encourage them to do what they like, you need to know that there is a risk of this atlantoaxial instability. The neck can, twist. If there's anything that affects the cord at the cervical area, it will lead to paralysis. So if they're engaging in any sports that will require them to be twisting and turning, and should be done with some level of precaution so that they don't end up having some adverse events. So the endocrine affectations include congenital hypothyroidism in 2% of them, diabetes mellitus, obesity, as well as hyperthyroidism. So because of the cerebral malformations, holoprosencephaly can be found in Patau syndrome. Microcephaly, microophthalmia, brachycephaly, that's flat occiput with a shorter fronto-occipital distance, and is found in Down syndrome. While prominent occiput is seen in Patau and Edwards syndrome. They have a lot of refractive errors, especially myopia, that might require some optical corrections. Glaucoma is also common. So when you see ophthalmos in a child, it's as if when you see ophthalmos, just know that the ocular pressure needs to be checked and an ophthalmic consult may be necessary. Intellectual disability is common. Now, there is most of them will have moderate intellectual disability with an average IQ of 24. Their IQ ranges between 25 and 50. And they have early onset dementia, early onset Alzheimer's disease. Before they get to 40, most of them will have this Alzheimer's disease.
Okay, so this slide, we have spoken a lot about the clinical features, and I can see that the labelings are not so clear. So let's just do a little teaser. What dysmorphic features can you see in this slide projected? So just in the chat box, just let us know the dysmorphic features that you can see in the slide that has been projected.
Let me see whether still.
Okay.
This one. Okay, we are getting some more answers to the questions. Okay, one person just gave the 3 differentials. Okay. Wow, this is wonderful. Okay. Okay, we are getting very wonderful responses. Okay. Preventive. Okay, somebody is asking what are the preventive measures for congenital heart disease in children. Okay, are there premarital counseling screening tests for congenital heart disease? Okay, so maybe by the end of the okay, prominent occiput, okay, that's good. Overlapping fingers, this is the clinodactyly, correct. Reduce what? This one is okay. Okay, so okay, at least we've gotten some very encouraging. Okay, you can see clinodactyly here. One of the responders said there was overlapping fingers, so which is correct. So this is clinodactyly. You can see the upper helix of the ear here. There is this additional folding. So this is one of the features. You can also see rocker bottom foot. You can see prominent calcaneal bone here. There is prominent occiput here. There is cleft lip here. So these are, then there is club foot. So this one that has a, once you see as a guide, once you see any child that has musculoskeletal problem, you know, or any congenital musculoskeletal issue on top, you know, as part of the dysmorphic features you're seeing, just know that it's likely Patau syndrome. Then once you see rocker bottom foot, think more towards Edwards syndrome. So that's okay. Thank you. So we have to move on. So we'll attend to the questions by the end of the discussion. So I think this is a clearer picture. You can see the prominent heel here. Prominent occiput, these plastic ears, small mouth and jaw. You can barely make out the neck here. Widely spaced nipple is not showing so much, but that's hypertelorism. So when you find a widely spaced nipple more in Patau Edwards, whereas in Down syndrome, whereas the eyes might be widely spaced, the nipples are closer. So that's one of the things that is like the other way around in Down syndrome when compared to Patau syndrome. Then clinodactyly is here, you can appreciate it. Okay. So this is a single transverse palmar crease, simian crease. You can also see camptodactyly. You can see the incurving of the little finger. So if this child or man now should fold the hands because of this curvature, because of the camptodactyly, there will be clinodactyly. This finger will overlap over this one. So you find a single palmar crease in all the trisomies. So a child with Down species, you can see the round face, you can see the mouth that is protruding, you can see the widely spaced eyes, hypertelorism. You can see the epicanthal fold. Okay, so then you can see the single, but this one did not get to the end. But this transverse palmar crease. So the other things that have been highlighted here are the things that you find in trisomy 21, also known as Down syndrome. So you can see a child with clinodactyly. The index finger is over the middle finger, the little finger over the ring finger. So this is clinodactyly, one of the features of Patau and Edwards syndrome. So for the diagnosis, of Down syndrome, there is horse criteria that can be a very useful guide. So once you see a neonate or a child now that has any of those features outlined, hypotonia or the palpebral features, or, upwardly slanting, or the single palmar crease or pelvic dysplasia. Once you find these features, just know that you might be dealing with case of Down syndrome. So this is a karyotype, one of the karyotypes that is showing an additional copy of a chromosome at position 21. So this is Down syndrome. So these tests are available. These are things that you can, do, or you can access sister centers that offer it to help you do. Okay.
So for investigations, any woman greater than or equal to 35-year-old should have genetic counseling, as was said previously, and a prenatal diagnosis. So while the woman is still pregnant, you can do serum screening, you can do an ultrasound, you can do the cell-free fetal DNA detection. I said is non-invasive, and then you can do the other invasive ones like amniocentesis and chorionic villus sampling. Also, you can do a fluorescent in situ hybridization. Yes. And then this can be a quick or rapid way to diagnose prenatal trisomy 13, 18, or 21. Sorry for the typographical error. So now we now deal with the quad screening. Before, we had known about the triple screening, but any woman that is offered screening for Down syndrome in the second trimester should have 4 of these maternal serum tests done. You can do a free beta human chorionic gonadotropin, that's beta HCG. You can do an unconjugated estriol. You can do inhibin and alpha fetoprotein. So to diagnose Down syndrome, you have the inhibin and beta HCG, you have them elevated, whereas the alpha fetoprotein and unconjugated estradiol, you have them decreased. And this is, diagnosis of Down syndrome. You want to do a chest X-ray, a plain abdominal X-ray is important. We talked about a lot of gastrointestinal,
like duodenal atresia, where you have double bubble sign. Echocardiography will help you delineate which structural heart disease the child has. Thyroid function test from the 3rd day of life. Though you don't do it the first day, because you might end up, getting the maternal hormonal level. So after 72 hours, thyroid function test can be done. Abdominal ultrasounds can help delineate, the presence of any renal, because some renal pathology can be found in children with Patau and Edward syndrome. Now, let me talk a bit more on the cell-free fetal DNA. DNA sequencing is the current thing now. With DNA sequencing, there is less invasive approach to the diagnosis, because amniocentesis and chorionic villus sampling, because of how invasive it is, it can lead to fetal losses. But cell-free fetal DNA detection, can just be used to pick up errors in the DNA sequencing. If there's any abnormality, any congenital abnormality, especially this trisomies 13, 18, and 21, the DNA sequencing can easily pick it. It's 100% sensitive and 95% specific. So it's something that a woman can do, in the first trimester. Just do it and see what is happening. Once that is done, and there's the diagnosis of any of those trisomies, from that point, the best treatment modality or monitoring can be offered, in terms of the management of these trisomies. So the treatments, the principles of treatment, first and foremostly, we need to understand that this is a multidisciplinary management approach. So the pediatrician will coordinate other subspecialists in the management of this child. We've highlighted all the systemic affectations in these children, from the cardiac to the orthopedic to the digestive or anorectal issues to obstructive sleep apnea to endocrine problems. So all these subspecialists listed need to be invited on board to ensure that the child gets the best available treatment modalities for those multisystemic problems. So for children, for women that want to take in, the age of conception above 35 calls for detailed genetic counseling, so that the risk of trisomies is explained to such women. And if they eventually take in and they are followed up and there are issues with the pregnancy as regarding the trisomies, necessary measures need to be put in place so that they don't end up having problems down the line. For instance, if the woman wants to put to bed now, facilities that have provision for specialist care, neonatal intensive care, pediatric cardiology, care, and other specialists should be considered, so that the baby doesn't come out and getting specialists to handle those multisystemic problems now become an issue. Now, proactive tailored care needs to be offered to each individual. What child A might require will definitely be different from what child B might require. A child that has congenital heart disease now might need different kind of treatment protocol compared to one that comes out without any congenital heart problem. So we should have at the back of our mind that whatever we are doing is individualized. You just give each child what the child needs. Now, medical management is indicated for infections like pneumonia, congenital hypothyroidism, and surgical treatments obviously will be required for structural heart problems like VSD that is symptomatic, or TOF. So those ones may require a proactive plan to ensure that these lesions are closed before there is reversal of shunts that might cause serious problems. And clinic follow-up is very, very important. So if you see a child that has dysmorphic features that will have gross developmental delay, that child will require some form of physical therapy that will help the child achieve the developmental gross motor milestones like neck control, sitting, crawling, standing, and the rest. Now, if you wait until they come back to you when these milestones have been long delayed, you will now start struggling about what you do for them. But if like we've had a child that had trisomy diagnosed within the neonatal period, and before the child got to 2-3 months, we already knew that the child would need some form of physiotherapy. So by 4 months, neck control was not there, physio was started. Before 5 months, the child was carrying the neck and was able to see it before 6 months and on. So clinic follow-up is very, very necessary, and long-term follow-up as well, because at every point in the decade of this child's life, there is always one problem or the other that might come up, even up to 40. For instance, we saw the early onset Alzheimer's disease. So if you don't follow them up to that point, the child might, develop the condition and nobody will really know what is happening.
Okay, so the principles of treatment. The first thing is we want to do a physical and occupational therapy. Now, depending on the age of the child, that would, infer the physical or occupational therapy. As we have said, physiotherapy as early as possible for children that are diagnosed in their neonatal period. Also, because we expect some developmental delays like speech delays. So speech therapy started on time for children that have developmental delays like speech delay. Also, we have noticed that children that have Down syndrome, they usually prefer, because of the intellectual disability they have, they usually prefer they don't usually like things like arithmetic and stuff like that, but they might prefer things like dancing and other things. So special education, like special schools that are tailored to, manage children with trisomies can also be, provided for the parents. Also, treatment of any underlying medical diseases. We also mentioned things like recurrent otitis media, things like that require medical treatment should also, in the course of management, should also be looked out for. Now, so for those that have a cardiac or digestive tract anomaly that needs, surgical correction, those anomalies should be detected early and surgical corrections should be done as indicated in either of them. Now, for those that have some form of visual or hearing anomalies, hearing aids can be offered to them early in time, and also wearing glasses for those that have visual problems can also be offered to them.
Okay, at this point, let's just check if there are questions or comments. Okay, yeah. Let me. Okay, so some of the answers to the teasers. Okay, a good number of people got the three case scenarios we painted, were all cases of trisomy 21 Down syndrome that were proven by karyotyping. So Down syndrome was the diagnosis. Then the differential diagnoses were Patau and Edward syndrome because they will equally have dysmorphic features. Then the treatment modalities, okay, somebody has already given the answer. Although we've talked about it, multidisciplinary management is very, very important. It's not something for one specialty to handle. All the different systemic affectations will need to be sorted out by the different subspecialists in those areas. Then, thank you, Rafiat, for that contribution. It was quite on point. Multidisciplinary management, counseling, speech therapy, surgery, educational or vocational support. Beautiful, awesome. Somebody's asking us to throw more light on post-axial position of the lower limb. Okay. Okay, so you're standing in an anatomic position. Anatomic position, I wish I was standing so that I demonstrate. So if you're standing in an anatomic position, your hand will be like this both ways, but your legs are the way they should be. So if you draw an imaginary line through any of the limbs, upper and lower limbs, the part of the line closer to the body is the preaxial. The part of the body away from that line is the postaxial. So the upper limb postaxial is actually here. We showed a picture of a postaxial polydactyly that you find in Patau syndrome in the lower limb. So in the upper limb. So the lower limb is actually the other way around. The postaxial is actually away from that line that if you draw a line through the limb. So that's, I think that's should answer the question. So great presentation. Please, what is the possible explanation for some young women less than 30 years still okay? So we had actually mentioned this, but maybe I should throw more light. Now, it's been documented that 20% of cases of Down syndrome, are actually delivered by women above 35 years. However, half of the cases of Down syndrome, that's 50% of cases of Down syndrome, is actually delivered by younger women. And the explanation has been because of increased birth rates. Now, if there is a very short interpregnancy interval, let's say somebody gives birth today now, and within the next 1 year, gives birth again, the interpregnancy interval is short, and that interpregnancy interval poses a risk of Down syndrome. So we've found that, in fact, even in most cases of Down syndrome that we've seen in this in our facility, is being to women that are younger than 35. And by the time you click around their previous confinement and all, you find that they had very short interpregnancy intervals. So that's why a lot of women that are less than 35 still give birth to. There should be the children should be pregnancy should be well spaced, at least more than 2 years, or 2 years at least in between both pregnancies, so that the meiotic event that happens will have enough time to be completed perfectly before the gamete is thrown into the factory to manufacture the baby. So that's I think that answers the question. This anonymous attendee. So that's what leads to that. What about overlapping toes? Is it associated with trisomy? Okay, so the same thing that happens in the upper limb can equally happen in the lower limb, but the characteristic dysmorphic feature we find in the lower limb in Down syndrome is the slipper sign. There's the gap between the big toe and the other toes. What are preventive measures for congenital heart disease in children? Okay, there's a study I came across that I don't know whether it was, but they couldn't establish the causal relationship between the absence of congenital heart disease, in mothers that had children with trisomy 21 without congenital heart disease. So there was a program, folate administration, that was offered to a population of women. So it was discovered that those that took folate, folic acid, now one of the supplements that pregnant women are usually given. So those that took the supplements, even though they had Down children, babies, they didn't have congenital heart disease compared to their other counterparts. So that's one study I saw that showed something that can be done to prevent congenital heart disease in children with trisomy. However, there is no preventive measure that has been documented, against having a child with Down syndrome. So that risk can be spontaneous. It can also, be sporadic. So nobody knows what causes it, but what has been shown is that the failure of separation of one of the gene at that position 21 is what, or 21, 13, or 18 is what leads to Down, Bartter, or Edward syndrome, respectively. Are there premarital genetic screening tests for congenital heart disease? Okay, so this one, we'll leave this one for our pediatric cardiology team. When they do their presentation, maybe they can go to town with congenital heart diseases. So for now, let's just stay on trisomies so that we don't one of our attendees doesn't end up taking us to where we don't know. Okay, how about reduce perineal body in a female child, where there is just a thin perineum between the vulva or anus? Well, maybe in the course of our research, we didn't see this. It's possible there could be something like that. Okay, okay, these were
The
answers to the picture we showed. How can a lady above 35 years be guided on having from having trisomy children? Okay, in as much as we've, at least in the statistics we shared now, it's the risk of having a Down child, a child with Down syndrome above 35 doesn't mean that women that are above 35 cannot give birth to normal babies. There are a lot of women that are above 35 that have given birth to normal babies. It's just that the risk is high. And just like there are very young women that are as young as 18 that have also given birth to people with children with Down syndrome. So these are just risk factors, which doesn't mean that once a lady is above 35, it's just that the risk is there. And when they take in, above this age, it will be wise to properly screen the pregnancies and follow them up to delivery and thereafter for trisomies. Thanks for the presentation. To be specific, I would say there is no treatment, but more of management. Okay, if there's an anorectal malformation and you do reconstructive surgery, it's not a treatment. So you treat the specific problems, but we need to look at the whole scenario, the multi-systemic management protocol that needs to be done. Okay. Apart from giving birth before 35 years, are there any other primordial and primary preventive measures for women above 35 years against trisomy? Okay, I've just shared one of the findings of a study that was done among women that were more than 35 years that took folic acid supplements, and the fact that their babies, even those that had dysmorphic features, ended up not having any congenital disease. So that's one of the documented preventive measures that can be offered. However, I'm yet to see any measure that can stop trisomy from happening. Something that can happen spontaneously, or so what are the environmental factors that affect women's eggs? If a prenatal screening shows trisomy, does he qualify a medical criteria for medically induced? Well, this one is an ethical question. So this is not something that one can say, give a yes or no answer to. If there are so many multiple congenital, in fact, nature has a way of ensuring that such pregnancies don't make it to term. A lot of spontaneous abortions that happen is because of trisomy. This has been documented. So if the multiple congenital anomalies the child has is not compatible with life, nature has a way of removing. But if it's not something that should be life-threatening, the child can be given should be given a chance to survive, because you never can tell. Every child is unique in their own right, so you don't know who is the Messiah we are looking forward to that might help us out of our current condition. Hope we will get this slide. Okay, definitely you get this slide. So I think that's okay. The last one. I don't know if you have mentioned this before. What is the risk for above 35-year-old in terms of chromosomal rights? Okay, so I think we've mentioned it now. The documented risk, for women above 35 is 20%. There is 20% chances, 20% chance that that a woman that is above 35 at conception could have a child with trisomy, when compared to the 50% of those that are below that have other risks like increased pregnancy rates. Now, it will interest us to know that the reason why those that are above 35 have a lower risk is because generally women above, if you look at the population of women above 35 that's taking, is just 5%. So if you're looking at the reproductive age of women generally, those that are above 35, only 5% of them, taking, compared to younger, those that are, younger. Majority of women that are taking are younger women compared to the older ones. So thank you. I think we've had a fair attempt at attempting all the questions. So we'll look at the outcome. The outcome seems better for children with or for patients with trisomy 21 when compared to those of 13 and 18. In fact, it has been documented that children with trisomy 13, less than 5% of them live beyond 6 months because of the multiple congenital anomalies, cardiac and renal. Whereas those with trisomy 18, less than 5% of them will make it beyond 1 year, of life, as compared to their trisomy 21 counterparts. So this is what the outcome looks like. So in conclusion, let me thank our audience for their active participatory listenership, and trisomies generally are important cause of neurodevelopmental delay. For most children with intellectual disability, majority of them have, in fact, part of when you see children with intellectual disability, a good number of them, it's due to trisomies and multiple congenital anomalies. Most children with multiple congenital anomalies also result from trisomies. So this causes a lot of psychological concerns for both the caregivers and the healthcare providers alike, because you have to spend a lot of time counseling these mothers that their children have some of these deformities. Some might even want you to, not to bother treating them of any condition. So our index of suspicion should be high, especially for high-risk pregnancies, women that conceive at those ages we mentioned, above 35, and babies with ovular dysmorphic or systemic abnormalities. With early and multidisciplinary management, we can improve the quality of life of children with trisomy. Okay, so we'll have some other things we want to tell you about. But before then, let's just look at further questions. If there are other questions, please. Good job.
Please, do you do telemedicine consultation?
Okay, I'll do. Okay, so our PR team will tell us more about the correspondence with the hospital, the telemedical aspect and things about referral. So let's just hang on while she highlights us on those aspects. Okay. Sorry, I meant for meals, not for. Okay, so there's also somebody asks, about the risk for males. There is also is in document. Some series will say the extra copy of the chromosome can actually be from the father. Some series say 5%, 95%, between 92.5 to 95%. The extra copy is from meiotic non-disjunction from the mother. So there's also the risk from the father. There's a series that say older men, men that are older than 40 years. Some say men that are older than 55, have a risk of having babies with trisomy. So some series, give values as high as 10% of the trisomies being from paternal non-disjunction. So just know that both on the father's side and on the mom's side, there is always that risk posed by increasing maternal and paternal ages. Okay, so we'll be talking to us about referrals. Somebody asked a question about consultations, consultation.
Hello, everyone. Good evening. My name is Pamela Haneje, the Corporate Relations Manager of the Limi Hospital Group. I just wanted to briefly introduce the Limi Children's Hospital to all of us tuned in for the pediatric webinar. First things first, we are located in Abuja, number 39 Adimola Adetokunbo, Wuse 2, at the Amak district. Okay, so the Limi Children's Hospital is an arm of the Limi Hospital Group that is dedicated to pediatrics. So strictly pediatrics cases, that's what we manage at the Limi Children's Hospital, ranging from neonates and general pediatric care from 0 months to 14, 17 years old. That's what we manage at the Limi Children's Hospital. And our specialties include neonatal intensive care and neonatology, other complex cases in pediatrics, radio diagnostics, including Doppler studies, maternal health, immunization, ambulance services, medical checkup, and the rest of them. Our core services include pediatric cardiology, pediatric neonatology, pediatric neurology. We accept referral from partnering hospitals. And for neonatal cases, we have a transport incubator that we collaborate with other hospitals with in terms of referral of newborns. We can partner with your hospital or clinic, and we're able to move a newborn or a neonate from place of birth to maybe a place of medical attention where they need a NICU service. So we can also collaborate with you through that aspect. And then again, we have some MOU signed with some other hospitals around Nigeria that they send their residents to practice with us at our hospital. Cardio care being one of our cardiology specialty. We have MOU with National Hospital and some other hospitals around Abuja and outside Abuja where they send their residents to us to practice. So we're also open to research collaborations, referrals, and every other collaborative opportunities that can happen between two healthcare workers or two healthcare facilities within Nigeria. Okay, so that is it for Limi Hospital. So we also have a medical hub where we discuss cases. We have tons of medical professionals on this WhatsApp group where we share cases and rub minds on advanced or peculiar cases that you might want to share with other people and get opinion on. On that platform, we also advertise our webinars. So to be up to date for all our upcoming webinars, we announce the dates and the topics there. So you can just look forward to it and register in time. And then talking of referral, we have different referral avenue. You can call us on 080-905-994. This number also will be available in the slide that will be sent to you, just in case you want to reach us. You can also send in a mail through limchildrenhospital@gmail.com or send your patients to number 39 at Demola Adetukumbo. And then we usually send out referral feedback to all the referring doctors, referring physicians that refer to the Limi Children's Hospital. That is what makes us different from every other hospital out there. We ensure that we carry the referring doctors along to, notify them on what has been done, the investigation, the medical attention, treatment, diagnosis, everything that has been done for your patient. We carry you along, we send you a feedback on that, and we send the patient back to you. So that is it for Limi Children's Hospital. So in terms of referring, we'd like you to also indicate your name, your email, your phone number, just in case maybe a doctor that is managing a particular patient you sent to us wants to reach out to you for a history or maybe previous diagnosis that has been done. So we can rub minds together to ensure that there's better patient outcome. Once again, thank you for your time. And then to also mention, we have the upcoming cardio care webinar coming up on the 28th of this month. That's last Friday of April. And it's a cardiovascular webinar. We're going to be talking about bradycardia, and our highly esteemed group medical director and interventional cardiologist, Dr. Esther, will be one of the hosts. And with a cardiologist in the cardio care hospital, Dr. Miriam Nwala, will also be taking on that topic. So I advise you look forward to it. If you're interested in joining, you can reach us via mail, and then we'll send the link to you. We'll still advertise it on all our platforms. You can register and join us for the next webinar on bradycardia. That's 3 p.m. Friday, 28 April 2023. Thank you for your time. The slide and the video recording of this webinar will be sent to your mail using the email you registered for the webinar with. Thank you so much for your time. If you have more questions, Dr. Gabriel Nwala, our pediatric neurologist, will be here to attend to you. Thank you so much.
On-site participants, you guys are so okay. So thank you for joining us for this monthly webinar. There are some questions that we just want to answer some additional questions that were asked in the course of the announcements. Do you do research collaboration? Yes, I think Mrs. Pamela talked about it. Yes, we do research collaborations. Limi Children's Hospital is a multi-specialty children's hospital. We have subspecialists in cardiology, neurology, neonatology, and researches in those areas can be done in collaboration with whoever that wishes to collaborate with us. So it's just to reach out to us and let's see your proposal and see how we can work it out. One of the participants asked whether there were additional environmental risk factors aside increasing maternal age. Okay, there's a series that studied women that had children with trisomies. So the 3 risk factors that they were able to document in that series was apart from increasing maternal age more than 35, smoking and use of oral contraceptives were other risks. So those that are taking oral contraceptive pills, the combined oral contraceptive pills, or those that engage in smoking also pose additional risk of trisomies. So I think that should answer Ruth's question. That's the second question Ruth asked us. Is your research collaboration only in cardiology? No. Okay, I've already answered. I think the previous answer should have answered that, not just only in cardiology, neurology and neonatology. In fact, we have one of the very good outcomes, in neonatal intensive care. Can a failed attempted TOP serve as a risk for? Well, this has not been documented. I just gave the documented risk: smoking, oral contraceptives, and increasing maternal age. I think that should be all. All the questions have been attended to. So let me thank us once again for actively participating in this webinar. We implore you to join us again for the other, with our monthly webinar series, not just for the Children's Hospital now, but the cardio care sister branch that will be having theirs, on Friday. So the email that you registered for this webinar with will receive the notification for the webinar, as well as the slides for this the webinar that we just had. Thank you, and thank you again. And from my co-discussants.
Thank you very much for tuning in, everybody.
Okay. So have a wonderful rest of your day. See you next month for another webinar series. Have a wonderful day.
The Limi Children's Hospital is a multi-specialty children's hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limechildren.org.